Welcome back to our session on cognitive impairment disorders. As you remember, we have been discussing about a variety of cognitive impairment disorders. In today's session, we are going to talk about two disorders in particular. We'll talk about delirium and we will talk about Parkinson's disease as well. We will start off with the disorder called delirium. What is delirium? The Diagnostic Statistical Manual of Mental Disorders, that is the DSM-4-TR, the text revision, defines delirium as a disturbance of consciousness which is accompanied by a change in cognition that cannot be better accounted for by a pre-existing or evolving dementia. Delirium develops over a short period of time. It can be hours to days and fluctuates throughout the course of the day. It is characterized by a reduction in clarity of awareness, inability to focus, distractibility, and change in cognition. Delirium is defined by DSM-4-TR in certain ways. Basically, it talks about a disturbance in consciousness, which means a reduced awareness of the environment. Next comes a change in cognition. Change in cognition means a memory deficit, a disorientation which is not related to dementia. The disturbance develops over a short period of time. It can be hours to days, as I said, and tends to fluctuate over the course of day, and there is evidence from the history, physical examination or laboratory findings that the disturbance is caused by the direct physiological consequences of a general medical condition. What are the various features of delirium according to DSM-4-TR? DSM-4-TR stipulates that as well as matching the definition which we have been discussing so far, patients must have certain clinical features. What are those clinical features? Basically, to start off with, disturbance of consciousness, a reduced ability to focus, inattention to reduced awareness of the environment, and a change in cognition or perceptual disturbance, including the memory deficits, disorientation, and language disturbance. These features develop over hours to days and fluctuate throughout the day, as we have already mentioned. As depicted in this figure which I am showing you now, the first feature is acute onset of mental status changes or a fluctuating course, and the second feature is inattention, and the third feature is on one side disorganized thinking or on the other side an altered level of consciousness. Putting together all these, we can see that a patient or a person is undergoing a state of delirium. Let us now look at the epidemiology figures. The prevalence depends upon the population. It's usually greater in medical or surgical population according to researchers. In the community population, you see it only about 0.4 to 2%. In general hospital admissions, 20%, on admission 10 to 15% of the elders, and during hospitalization up to 40% are said to show delirium. And at the end of the life, about 83% of the people are said to demonstrate delirium. At any one time, delirium may affect between 1/2 and 1% of the population and from 10 to 30% of the hospitalized patients. Up to 1/4 of hospitalized cancer patients and up to 40% of hospitalized AIDS patients, according to studies, develop delirium at some point. As many as 80% of people with terminal illnesses develop delirium near death. The elderly, as noted earlier, have a high prevalence of delirium. In frail geriatric groups especially, at least 250 different contributing factors towards delirium have been identified, the most common of which are infections, adverse metabolic events, and adverse medication effects according to research studies. Let us look at how DSM-4-TR classifies delirium according to etiology. Why I am saying etiology, you will understand as I talk about it. There may be a delirium due to general medical condition. There may be delirium which is attributed to substance intoxication, that is drugs of abuse. It is called substance intoxication delirium. Then there is what is called substance withdrawal delirium. There is substance induced delirium because of medications or toxins. and delirium due to multiple etiologies, delirium not otherwise specified according to DSM-4-TR. Clinically otherwise, delirium is divided into three categories. First is called hyperactive delirium, which is seen in about 30% of the cases. Patients here are agitated, they are hyper alert with repetitive behaviors, wandering, hallucinations and aggression. Although recognized earlier, there is association with increased use of certain medicines like benzodiazepines, oversedation, use of restraints and falls. Another type of delirium is called hypoactive delirium, which is seen in 25% of the people. Patients here are quiet and withdrawn, and this is often missed thus on a busy medical ward, leading to increased length of stay because of this being too quiet and withdrawn, increased length of stay, increased and more severe complications. Another type of delirium is called mixed delirium. Here there is a fluctuating pattern which is seen in about 45% of the cases. Let us have a brief look at the causes and the precipitating factors of delirium. Diseases which can cause inflammation and infection like pneumonia can interfere with brain function. Additionally, also taking certain medications or abusing drugs can disrupt the chemicals in the brain as well. Alcohol withdrawal and eating or drinking poisonous substances can also cause delirium. Delirium is very common, as mentioned earlier in the first module, in the elderly after they have had surgery especially, and patients over 80 being particularly at risk according to certain studies. Vulnerability is also increased when multiple precipitating factors are present. Sepsis, shock, hypothermia can be problems too. Electrolyte disturbance, especially with reference to sodium, calcium, magnesium, phosphate can be a reason. Endocrinal disturbance like differences in blood sugar and thyroid can also be a problem. And of course, nutritional deficiencies with respect to thiamine, B12 and folate among others are also important. Most elderly patients are supposed to have multiple risk factors, making them more susceptible to delirium, as we have been seeing while we were discussing about the age groups and about the prevalence. We have been saying that elderly are more susceptible. Why? Because there are multiple risk factors. Delirium is often only a sign of an underlying serious medical illness in an elderly patient, and therefore particular attention has to be given to identifying and correcting these factors which are underlying. Surgery patients and people who are withdrawing from alcohol and drug abuse are also at risk. Conditions which damage the brain like stroke and dementia can also increase the risk. Extreme emotional stress can also be a factor. In addition, there are certain factors which may also contribute to delirium like sleep deprivation, certain medications like sedatives, blood pressure medicine sometimes, and sleeping pills and painkillers. In addition to these, the other factors may be dehydration, poor nutrition and infections like urinary tract infection. There may be certain other reasons too, like cardiac, liver or renal failure, pulmonary disorders, particularly in the setting of what is called hypoxemia, then CVA or seizures, post-surgery, especially cardiac, orthopedic or with ICU stay. Certain falls and fractures can be contributory, anemia or gastrointestinal bleed can contribute, pain, cancer, terminal illness, cerebrovascular accident, all these can be said to be the factors. Not all at a time, but each of these may have their own contributions towards delirium. Now, having said that multiple factors cause delirium, what about the prevention? Prevention is possible, and this can be divided into primary, secondary and tertiary types of prevention. Primary prevention strategies are aimed at reducing the incidence of delirium, and secondary prevention requires optimal clinical management at the time of delirium, when delirium actually occurs. And tertiary prevention strategies, on the other hand, require identification of the previous episodes of delirium by taking a careful history to recognize those who are high risk individuals. Management of delirium is also possible, provided we take care of certain factors. We know that delirium is a multifactorial problem. Hence, multidisciplinary interventions are required, and they are more likely to produce the most success. There are certain studies, for example like Bergman and others, who have proposed a model or care for management of delirious patients in the acute setting with a standardized approach which involves 4 key steps. The first step, according to Bergman and others, is the assessment of delirium symptoms in new admissions. Thereafter, the second step would be evaluation and treatment of reversible causes of delirium. The third step then would be prevention and management of common complications of delirium, and finally restoration of cognitive and self-care function in delirious patients. Now let us discuss about another cognitive impairment disorder, that is Parkinson's disease. This is the second most common neurodegenerative disorder after Alzheimer's disease, as we have discussed in the earlier sessions. And the prevalence of Parkinson's disease is 1 per 1,000. This was first described way back in 1817 by an English physician called James Parkinson in his An Essay on the Shaking Palsy. Mind this word, shaking palsy. The causes of Parkinson's disease are not clear, although both genetic and environmental factors, like for many other diseases, they are suspected. Parkinson's disease is characterized by a progressive loss of muscle control which leads to trembling of the limbs and head while at rest, stiffness, slowness and impaired balance. As you are seeing in the picture which I am showing right now, as symptoms worsen, it may become difficult to walk, talk and complete simple tasks. The progression of Parkinson's disease and the degree of impairment vary from individual to individual. Many people with Parkinson's disease live long productive lives, whereas others become disabled much more quickly. Premature death is usually due to complications like falling and the related injuries or pneumonia. Most individuals who develop Parkinson's disease are 60 years or older in age, and Parkinson's disease occurs in approximately 1% of individuals aged 60 years and in about 40% of those aged 80 years. There are 2 types of Parkinson's disease which we talk about. One is adult onset Parkinson's disease. This is the most common. But then there is also what is called early onset Parkinson's disease, where the onset is between 21 to 40 years. Now there is one more in addition to these 2 which we should talk about, which is called juvenile onset Parkinson's disease, where the onset is before the age of 21. And Parkinson's disease is supposed to be more common in men than in women according to studies. The primary symptoms of Parkinson's disease are all related to voluntary and involuntary motor function and usually start on one side of the body. Initially, the symptoms are mild and will progress over time, and some individuals are more affected than others. As I have shown in the picture that you have just seen, there are certain motor symptoms. The first of the motor symptoms that we should discuss is tremors. There is a trembling in fingers, hands, arms, feet, legs, jaw or head. And tremors most often occur while the individual is resting, but not while involved in a task. Tremors may worsen when an individual is excited, tired or stressed. Another feature which is important among the motor symptoms is rigidity. This indicates the stiffness in the limbs and trunk, which may increase during movement in particular. Rigidity may produce muscle aches and pain. Loss of fine hand movements can lead to cramped handwriting, which is called micrographia, and may make eating also difficult. There is another symptom called bradykinesia, which is slowness of voluntary movement. Over time, it may become difficult to initiate movement and also to complete movement. Bradykinesia, together with the stiffness which we have just been discussing, can also affect the facial muscles and can result in an expressionless mask-like appearance. As seen in this figure, there are three cardinal symptoms overall that we have been discussing so far. One is a resting tremor, the second is bradykinesia, which is a generalized slowness of movements, and the third is muscle rigidity. In addition to these symptoms, there are also certain other symptoms, like for example, postural instability, which become a part of the motor symptoms. Impaired or lost reflexes can make it difficult to adjust the posture to maintain balance, and postural instability hence may lead to falls. Another important symptom, which is motor symptom, is Parkinsonian gait. Individuals with more progressive Parkinson's disease develop a distinctive shuffling walk with a stooped position, as shown in the figure which I have just demonstrated to you, and a diminished or absent arm swing. It may become difficult to start walking and to make turns as well. Individuals may freeze in mid-stride and appear to fall forward while walking. So let us just look at this figure and then see what are the major symptoms. As indicated in the figure, there is a rigidity and trembling of the head. There is a forward tilt of the trunk, as you are seeing. There is a reduced arm swinging. There is rigidity and trembling of extremities, and there is a shuffling gait with short steps. In addition, as you are seeing in this slide, there is what is called repetitive pill rolling movement, as indicated by the arrow in the figure. And of course, there are persistent tremors, as also demonstrated in the earlier pictures that I have shown you, and there is a shuffling gait taking small steps. All these symptoms are indicated in the picture that I am showing to you. Now let us also discuss briefly about the secondary symptoms in addition to the motor symptoms that we have been talking about so far. While the main symptoms of Parkinson's disease are the movement related, which we have discussed so far, progressive loss of muscle control and continued damage to the brain can lead to secondary symptoms as well. These symptoms vary in severity, and not every individual will experience all of these symptoms. Some of the secondary symptoms can be anxiety, insecurity and stress, confusion, memory loss and dementia, which is more common in elderly individuals, and constipation, depression, difficulty swallowing and excessive salivation, diminished sense of smell, increased sweating, skin problems, slowed, quieter speech and voice which is monotonous, monotone voice it is called, urinary frequency and urgency, and many other symptoms as well. So far we have discussed about various symptoms of Parkinson's disease. Let us also have a brief look at the causes leading to Parkinson's disease. The primary area of the brain that is affected in Parkinson's disease is substantia nigra. It contains a specialized set of neurons which send signals in the form of a neurotransmitter called dopamine. The signals travel to the striatum via long fibers called axons. The activity of this pathway controls normal movements of the body. When neurons in this area degenerate, the resulting loss of dopamine causes the nerve cells of the striatum to fire excessively. This makes it impossible for people to control their movements, leading to the primary motor symptoms of Parkinson's disease that we have been discussing at length. Many Parkinson's patients eventually lose 80% or more of their dopamine producing cells according to studies. In most individuals, Parkinson's disease is idiopathic, which means that it arises sporadically with no known cause. However, about 15% of the individuals have family members with Parkinson's disease. By studying families with hereditary Parkinson's disease, scientists have identified several genes that are associated with the disorder. Having said that these are the causes, let us also try to identify some of the risk factors behind Parkinson's disease. Most people who develop Parkinson's disease are older than 60 years of age. Men are affected about 1.5 to 2 times more often than women, and a small number of individuals are at increased risk because of family history of the disorder. In addition, head trauma, illness, or exposure to environmental toxins such as pesticides and herbicides may also be risk factors. Having considered the causes, the symptoms, the causes, the risk factors, let us also look at the possibilities of treatment too. Currently, there is no treatment to cure Parkinson's disease. Several therapies are available to delay the onset of motor symptoms and to ameliorate motor symptoms. All these therapies are designed to increase the amount of dopamine. Remember the explanation that I have given a short while ago. So these therapies are designed to increase the amount of dopamine in the brain, either by replacing dopamine or mimicking dopamine or prolonging the effect of dopamine by inhibiting its breakdown. Let us look at an overview of the management of this disease based upon the various clinical features. On the left hand of the figure, which I am demonstrating to you now, you are able to see the clinical features like head bent forward, tremors of the head, mask-like expression, drooling, rigidity and all. And on the right side, you see the management. Like for the clinical features which are listed on the left side, namely head bent forward, tremors of the head, mask-like facial expression, drooling, rigidity, stooped posture, weight loss, tremor, akinesis, which is absence or poverty of normal movement, loss of postural reflexes, bone demineralization and shuffling or propulsive gait, all these which have been discussed at length so far. You see on the right side, the management techniques are drug therapy, rehabilitation, client and family education. It is the caretakers who may undergo certain problems because of the regular care that they have to take, and which may be overburdening. Many a times it may be overburdening. Hence, client and family education about the problem, awareness created about the problem, and the ways of management being explained to the family and the caretakers, the primary caretakers, especially be it spouse or children or whoever the primary caretaker is very important. In addition, in order to help them with problems like rigidity, warm baths and massage to relax muscles may be helpful. Then specific drug therapy may be used for the weight loss and tremors. Well, routine has to be established. And then self-help devices to meet daily needs like for example raised toilet seat and long handled comb and razor, in order that they manage themselves in a better way because of their loss of postural reflexes, and because they cannot have a normal movement, they need to have some support systems like I have described just now. In addition to that, since there is a rigidity and there is bone demineralization which may result in further problems with relation to rigidity and tremors, exercise to loosen the joint structures may be of some help, and a range of motion exercises to prevent deformities can be of some help. Put together, all these management support may help the individual and his family in managing his situation a little better. And studies have shown that early therapy in non-motor stage itself can delay the onset of motor symptoms, thereby extending the quality of life of the patient so that he doesn't become too dependent upon others, which may result in a variety of psychological problems as well. An alternative approach currently being explored is the use of dopamine producing cells derived from stem cells as well. For some individuals with advanced, virtually unmanageable motor symptoms, surgery may also be an option. In addition to medication and surgery, general lifestyle changes like rest, exercise where necessary, when necessary, and the way it is necessary. In addition to that, the physical therapy, occupational therapy, speech therapy, all these put together may be helpful to the individual as well as his family in the management of Parkinson's disease.